cartilage from we could take cartilage from a good part of your knee and grow that up in a lab, and then come back and reimplant that in this cartilage defect. And then over approximately 3 months or so, you have regrowth of cartilage. So we're able to regrow cartilage. So we are on our way to a biologic cure, but right now it's really for isolated defects. Originally, when we started doing this, we were able to fill in what I quote unquote call potholes, is the best way to explain it. Originally, it was the size of a dime and then a nickel. Now we're up to about a quarter, hopefully soon to be a $50 size that we're able to reconstruct. And then eventually, maybe we'll be able to reconstruct the entire joint, which would be from an arthritis standpoint. Next slide. So this is the technique. I take another way of doing that would be these osteochondral plugs. So instead of growing up those cells in a lab, the other way of doing it is I can take plugs with cartilage on top and bone on the bottom and take them from areas of the joint that we don't believe are articulating and are there basically for us to harvest. And then we could put them in that defect. So two ways of treating it. One would be grow up the cells in a lab and reimplant them. Or the second way would be to take your own cells and do an autologous osteochondral grafting transplant technique. Next slide. So Carticel is the autologous one. We sort of went through this, but this is that growing up of cartilage. Next slide. So arthritis, again, often called wear and tear. Most common is osteoarthritis, but there's roughly 80 or so different types of arthritis. You know, the next most common would be rheumatoid arthritis, Lyme's disease, gouty arthritis, all the inflammatory type of arthritis conditions out there. But basically, it's a breakdown of the cartilage that cushions the hip and knee joint. As that cartilage breaks down, the result is bone-on-bone friction, which leads to pain, loss of movement, and a gradual weakening of the unused muscle. So it's just a paradigm that keeps going downhill. But again, the real key here is the definition. So it's loss of cartilage. God bless people every day. They come in and they're asking me, hey, doc, can you go in there and take out my arthritis? There's nothing for me to take out. It's a loss of cartilage. Go back to that analogy of a tire and you lose the treads. That's the best way I can explain it. And when you look at x-rays, and I show people weight-bearing x-rays, and again, the key there is weight-bearing x-rays, it really gives you a good idea of how close those bones are to each other. And it really gives people a good visual of how much cartilage they had and then how much cartilage they have lost. Next slide. So one of the treatments that's new and exciting are these different nutraceuticals. There's mixed data, but glucosamine and chondroitin sulfate, this is one of the products that was well studied in an NIH-funded study called GATE. They looked at cosamine DS, this brand, versus Celebrex versus placebo. And as you can see, the nutraceutical actually did pretty well. So it has less side effects than the anti-inflammatory medicine, and it can actually do better than Celebrex in some of the studies when it comes to moderate and severe pain. You know, the downside is that there's all kinds of results, there's all kinds of brands, there's no regulation whatsoever when it comes to what product is being sold. And unfortunately, in over-the-counter products in this country, given the unregulation, sometimes you can't even absorb the product that somebody's trying to sell you. So it's sort of the wild, wild west of medicines out there. But at least this product was studied in a pretty good controlled study, and it's the one I recommend. It's a little more costly than some of the other products, but they do have a patent. I have no financial interest, but it does seem to have some good data if somebody wants to try it. The downside is they're rather costly for people that are on fixed income. So again, we don't like to promote anything as doctors because people take our word sometimes as gospel, and we have to be careful. Next slide. Injectable medications, really there's two. We'll go into some other ones, but the two that are approved by insurances, one would be hyaluronic acid and the other is cortisone. Let's go over each one real quick. You know, cortisone's an anti-inflammatory medicine, as we all know. Again, the process of arthritis is loss of cartilage. That's the mechanical problem. That goes on to trigger an inflammatory reaction. That inflammatory reaction in some patients is rather high. So if you give them a cortisone shot, you can reset that inflammation, take away that inflammation, at least temporarily, right? So sometimes it goes away for a couple days, a couple weeks, a couple months, a couple years. and it's all variable. So it's just resetting the inflammation. Hyaluronic acid, on the other hand, is a molecule that's normally secreted by the cartilage. And what it does is it increases the viscosity of the fluid in people's knees. So what the process there is, hey, if people have arthritis, they have loss of cartilage. Loss of cartilage means less hyaluronic acid. So some smart people got together and said, hey, let's take that fluid out of arthritic knees and let's analyze it. And lo and behold, it was very thin, more of a watery substance than an oily substance, and it lacked hyaluronic acid. So the process was, well, let's inject hyaluronic acid back into that knee, and at least we can try to increase the viscosity of the fluid of the knee to make it a better lubricant. It's got all kinds of names, WD-40, chicken fat, but basically it's all the same. There's 6 or 7 products out there. They all work relatively the same. There's no one clinically better than the other. And it usually comes in a 1 or a 3-shot series. Next slide. Just to touch on the other ones before we move further would be that there's PRP, which is platelet-rich plasma, not approved by most insurance companies, if any insurance companies outside of workman's comp. And what that does is we take blood from patients, spin it up in a centrifuge for about 15, 20 minutes, and then we're going to take a certain layer, which is rich with platelets and growth hormones and different kinases. And we think we're getting some benefit if we inject that back into the knee. So that's out there. It's, it's cash only type of thing right now. So it's, again, not approved by insurances. So sometimes that's frustrating for patients that have tried other modalities, and it can be rather costly. We basically charge the minimum. Other, facilities, you can charge whatever you want. So it can be anywhere from up to $2,000, $3,000. We try to stay around the $800-900 range because we have to buy the kit and do an office visit and do an injection, all of which are outside of insurance. The other injectable products out there are stem cells, whether it's adipose, mesenchymal cells, and they're starting to gain some traction. The data is all over the place. Right now, we're not convinced that injecting a free-floating stem cell in a knee is going to find its way to the cartilage defect and then repopulate cartilage. They are starting to work with some collagen scaffolding grafts, which I think have some promise, sort of analogous to that technique I showed you before. However, again, we're able to fill in potholes. We're having trouble resurfacing the whole road. That would be the difference in arthritis versus isolated defects. So joint replacement. So a lot of new and exciting things in joint replacement. A lot of the buzzwords in surgery is minimally invasive. And the bottom line is, in my 16 years doing this, basically we were maximally invasive before. Now we're minimally invasive. We're once where we made gigantic incisions and cut every muscle, getting down to the joint. We're now over time have realized that we can do the same surgery with smaller incisions, but it's not so much the incision that's important or the length of incision, even though we get caught up on that sometimes. It's really that we're doing less soft tissue damage, right? The trauma is significantly less. When joint placement started, when I first started doing it, it was, the patient had a significant problem, an arthritic knee and arthritic hip. And then we took that problem and we remedied it with a joint replacement. However, the trauma that was associated with that procedure was tremendous, especially with knee replacement. And it caused such significant surgical trauma that sometimes even patients wouldn't come back for their contralateral side. But these minimally invasive techniques have really, really led to shorter hospital stays, faster recovery, less blood loss, and an overall better subjective outcome for patients. Next slide. Real quick, again, on the left, you see a natural hip joint. On the right, an arthritic hip joint where the cartilage gets diseased and starts to wear away and osteophytes form. Next slide. So again, traditional incision in the red, pretty maximally invasive, cut a lot of tissues. Now you can see a smaller mini incision. And the idea is whether you sneak around the front of the hip in an anterior approach or sneak around the back of the hip with a posterior approach, you're just going in front of the greater trochanter or behind the greater trochanter, both of which have tremendous outcomes when it comes to the amount of time that it's up to recovery. In so much as if I operated this morning on a hip patient, they would be walking this afternoon doing steps and able to walk around their the room, whether you did an anterior approach or a posterior approach. Next slide. And then I put these components in. I put a shell in the acetabulum, and then a plastic liner, followed by a metal or ceramic ball, and then a femoral stem, and that makes the new articulation. Next slide. Same with the knee. You can see a healthy knee on the left, good cartilage, diseased knee on the right, arthritic, loss of cartilage. Next slide. Again, traditional knee incision, we would cut through the quadriceps tendon. Mini incision on the left, you can see I do a quad sparing approach to knee replacement, which basically makes, like the name implies, if I don't have to cut your quadriceps tendon, which is a rather large tendon in your knee, then you don't have to recover from that trauma, which then leads to quicker recovery, which is a less pain and a speedier rehab. Next slide. Knee replacement involves putting components on the end of the bones where there was once cartilage. Now you can see there's metal, and then there's a plastic liner that acts as the articulation. On the right side, you can see a partial knee replacement, same philosophy. It's metal, plastic with a metal on either side of the femur and the tibia, and then a plastic insert, which is now the new articulation. Partial knee replacements are good when just one part of the knee is diseased and the rest of the knee has excellent cartilage. Next slide. So reported benefits, again, of these less invasive surgeries. Cosmetically, patients like the smaller incisions, but really the key is less pain, less muscle damage. Rehabilitation is faster and shorter hospital stays, all which leads to a much better experience for the patient and better outcomes. And as you all know, with alternative payment models and the different ways we're getting paid nowadays, quality is important. So we're trying to, look at patient-reported outcomes, and how patients are grading us is not only important on social media, but it's also important from the payer standpoint, and they want to see high quality for their expensive surgeries that they're paying for. So it's really important that we kind of go in this direction, not only clinically, but also from an overall standpoint financially. Next slide. The key, what has really changed joint replacement outside of the minimally invasive surgical technique, is really how we're addressing pain management. And nowadays, the buzzword is multimodal pain management approach. It's really revolutionized joint replacement and orthopedics in general. And the idea is we're really understanding the pain pathway. And that pain pathway starts preoperatively. I give people Celebrex, gabapentin, and Tylenol, all of which to try to initially stop the brain from feeling any type of surgical procedure or damage that's caused by the surgical interruption of their skin and muscles and tendons and bone. So if we can block that pathway before we start, then we have a significant better chance of alleviating people's pain, right? And back in the day when I first started, we would use a general anesthetic, do a very traumatic surgery, and then give patients a PCA pump. And I would go on rounds the next morning, and patients would be throwing their trays at me, for God's sakes. They were so miserable. They were writhing in pain and really having a difficult time at it. Now you can see preoperatively, Celebrex, give anti-inflammatory medicine, gabapentin, a neuromodulator, and then Tylenol. And then intraoperatively, we do a spinal anesthetic. And then what's really revolutionized joint replacement is a periarticular injection, which is a cocktail of medicines that involves ropivacaine, which is a long-acting cane product, which is less cardiotoxic than other canes, Toradol, which is an anti-inflammatory medicine, and epinephrine to keep that product around there. And then post-operatively, immediately we go right back on the regimen of Celebrex around the clock, Tylenol around the clock, gabapentin around the clock, and then we use tramadol for first rescue, and then oxycodone as our last rescue. And what's amazing is there are some patients that never even get the tramadol, and rarely nowadays does anybody get the oxycodone, right? So we really have changed the paradigm, and especially in this day and age when it comes to narcotic use and dependence and where this country's gone over the last 15 years. It's really been a problem. And partly as surgeons and orthopedics, we were probably part of that problem. the knee-jerk reaction was everybody got 60, tablets of Percocet for whatever procedure they had. And now we're really, giving people 10 tablets of oxycodone, and rarely do they use them. So this multimodal pain management approach has really revolutionized what we do in joint replacement. And again, now we're looking at joint replacement. If I operate this morning, the patients are walking this afternoon, they've already had physical therapy session, and then in some cases they can go home the same day. If not, they stay overnight, have breakfast the next morning, do some therapy in the afternoon, and roughly 95% of the patients are out the door by 24 hours, give or take. And then out the door is out the door home. So what we've changed also is how patients and what their dispositions like, right? So back in the day, general anesthetic, in the hospital 3 or 4 days, use a PCA pump, go to a rehab hospital for 7, 10, 14 days, and then go home. So now we're multimodal pain management approach, minimally invasive surgery, potentially go home the same day as an outpatient procedure. If not, go home within 24 hours, 95% of the time, and then go home. You're going home with therapy coming out to your house if needed. And what that's shown is, again, the quality metrics of joint replacement has changed dramatically, and so has the cost. We're driving a lot of the cost out of joint replacement, which is great for the overall society and our healthcare system, which is obviously in disarray. And it's also allowing us to have metrics by which the insurers and the payers are seeing a benefit from the surgery that we're doing. And we really needed to do it in joint replacement because the numbers are staggering with the baby boomers and what it's going to cost our health system. So we really were driven to do something because we just had exorbitant costs when it came to what it was taxing the system. So that has changed dramatically. And then what we've realized is our readmissions are lower, our hospitalization is lower, our infections are lower. And that's what we tell patients. Look, if you go home, you have a much better chance that none of this bad stuff is going to happen to you. Next slide. The other thing that we've really revolutioned is the joke was, as orthopedic surgeons, all we cared about was orthopedics. And interesting enough, now we care about everything because we've turned into all kinds of subspecialists. And what I mean by that is patient optimization is what has really been key in surgery and in orthopedics in general. And my job as a surgeon is to work with the primary care doctors and really address optimizing the patient for surgery. Back in the day, believe it or not, we really didn't optimize too many patients at all. We would just say, hey, you need a knee replacement, you need a hip replacement, are you cleared? Okay, let's go to surgery. Now we're looking at diabetes, and if your hemoglobin A1C is too high, roughly over 7.5, well, it's not worth going to surgery right now because the perioperative risk of surgical site infection is too high. So we don't want to take that risk with a modifiable risk factor. The other thing is nutrition. We care about people's nutrition now because if you need wound healing and you want to fight infection, you better have a good nutrition and in your body. So you really have to work on that. So we do that. We're looking at anemia, right? We don't want patients to have preoperative anemia. That can be reversed because that's been shown to increase your hospitalization, increase your readmission. And if you get a blood transfusion, which is really rare nowadays, it's going to also increase your risk of complication. Smoking's a no-no. Total hip replacement, we won't even do total hips in smokers now because that prosthesis needs bone ingrowth, and smoking directly inhibits bone ingrowth. So we really stay away from that. Most surgeons, myself included, really counsel patients on smoking cessation, and they really need to do that for hip replacements. The other problem is, even though a total knee is cemented in for the most part, it still has wound complications because it has such superficial skin and bone underneath in the knee versus the hip. The wound complications in knee replacement are high in smokers. So we really try to address that. And again, it's a modifiable risk factor, albeit very hard to modify. I don't imagine that it's not, but it is something that can be changed and we need to change it. Weight loss is paramount. We're working with Abby and over at the Bariatric Center, and we're trying to drive, a coordinated effort. In our literature, it's very clear that if we do the bariatric surgery and that consultation beforehand, then the patients do better from a joint replacement versus, back in the day, we used to think, well, we'll do the joint replacement and then they're going to lose weight, but that doesn't really happen. Usually, unfortunately, people's BMI goes up after joint replacement, usually because people's BMI usually goes up in life in general. So it's been studied pretty clearly that the best order would be to do the bariatric surgery and intervention and then do joint replacement. And this has all led to better outcomes, less readmissions, lower costs, higher quality, and then for alternative payment models, these APMs, it's really been able to drive a working relationship with the payers. So patient optimization is really key. Next slide. So joint replacement bearing surfaces. So for the most part, in a knee, it's metal on poly is pretty much the tried and true. It's been ongoing for the last 25 years or so. Not too much difference there. Hips have gone through a different shift. It was metal on poly, and then metal on metal came on board, then ceramic on ceramic came on board. And now ceramic on poly is probably the gold standard. It gives you the best upside, which is less wear of the polyethylene without the downside of metal on metal, which has unfortunately, in a lot of the makers and some of the companies pulled their joint replacements off the market because of the metal toxicity and ions that were being produced. Ceramic on ceramic, also a good articulation because it had less wear, but it had squeaking and it had some brittle effects. So sometimes they were breaking. So obviously that's not a good outcome. So really it's metal on poly for hips or ceramic on poly for hips is the joint surface, but sometimes people have questions about that. But it's we're always working to try to find a better surface, but that's where we are now. Next slide. Again, that's what that looks like. On the left, you got metal on metal. So that liner, instead of being a plastic liner, is a metal liner. On the right, you can see that's a ceramic liner instead of a plastic liner. On the left, that's a metal head. On the right, that's a ceramic head. Next slide. The next new and exciting thing is robotic assisted surgery. Obviously robots have gained a lot of steam over the last several years in multiple disciplines in surgery, and they've also done that in orthopedics. So we're now actively looking at a robot for Nazareth Hospital, and the idea would be that we're going to try to be more reproducible, right? So right now we're using a lot of techniques and jigs and measuring devices intraoperatively to put these joint replacements in the correct position. And the idea that is if we can get a preoperative X-ray, a preoperative MRI, or a preoperative CAT scan, which is really looking at the anatomy in detail, put that into a computer software application, and then the computer kind of digests all that and with different proprietary algorithms comes up with the correct way of cutting the knee and shaping the knee to put the joint replacement, within 1 degree or so of where it needs to be and within 1 millimeter of balancing ligaments and soft tissue structures. And then the idea would be if we can balance the joints better after a joint replacement, and if we can put the joint replacement in a very reproducible, correct position, it makes sense that the outcomes would be better. So that's what we're all looking at. Like any other medical literature, it's going to take time for us to kind of vet that out in the literature, and it's being studied actively. The early results, 2 years, and some of which are up to 5 years, show excellent outcomes. But the longevity and where you're going to really see that is, year 15 through 20. A lot of things in orthopedics and medicine do well the first couple years. It's really your long-term outcomes that you're trying to improve. So it doesn't seem like right now there's a huge difference in short-term outcomes, but we're really betting on the fact that our long-term outcomes are going to be better. And what that can do then, if there's less revision surgeries, which are amazingly costly to society and healthcare and system in general from a financial standpoint, and it's also severely costly from a morbidity and mortality standpoint from a patient perspective, because that second surgery and potentially third surgery are significantly harder to do than the first surgery. It's not impossible. We do them, and that's what we're trained to do, but it's different. I mean, I give the analogy to patients. I grew up, my family built houses. So, we would build new houses, and new construction's easy. I put the foundation down, I frame out the house, and it's very simple. The angles are very reproducible, and everything's square. Whereas you go in and you have to redo somebody's house, much different. Taking drywall down and molding down and not damaging underlying framing and structures is much more challenging. So it's much easier to do it one time, do it correctly, do it the best we can, and hopefully never have to do it again, and versus having to redo it. So we're really looking into robots to be maybe one of the missing pieces to that long-term outcome that we're looking for, that will give us better outcomes and less revisions. Next slide, please. So this is what robots look like and computers look like. This is a computer-generated model, so it's looking at different sensors and transducers in the knee, which then get relayed to the computer to look for proper alignment. Next slide. And then it gives you images. So instead of me eyeballing where I'm going to put my reamer, which is that bottom right-hand picture, or where I'm going to put the shell in the patient, you're able to do that with a reproducible model using computers and robotic-assisted surgery. Next slide. All right, so I think that's where I'm ending up. There's my family again, so I thank them for all their time that they've given me and allowed me to pursue what I love to do. And again, in closing, joint replacement, it's really come a long way. I think it's a great modality for patients, and it's really changed people's lives in a positive way. So I thank you for your time.
Thanks, Dr. Selgrath. That was a great overview of what we do in the OR as far as joint replacements and what happens to our patients pre and post operatively. So I'm going to open it up to anyone on the line who has any questions for Dr. Selgrath. You can put it in the chat, or you can just take yourself off of mute. If you can't get off of mute, star 6, I think it is, or 6-9. I'm not sure which one gets you off of mute. And then I do have a couple of questions for you, Dr. Selgrath, that we got during the meeting here. What are some patients not happy with during their post-op recovery and, progressing into doing their activities of daily living? Are they have some concerns? What would PCP hear?
Yeah, so what you're going to hear is particularly in knee replacement. So if we start there, right now, subjectively, it can be 20 to 28% of patients are not subjectively happy with their knee replacement. So knee replacement's always been somewhat of an enigma when it comes to that, whereas hip replacement, subjectively, 95, 96% of patients are subjectively happy with their hip replacement, right? Nobody's going to always be happy. But when 20% or over 20% of your patients are not subjectively happy with a surgery, that's not a great outcome, right? So somebody sends me a patient and then I do a knee replacement on them, and then they go back to their treating primary care doctor and they hear, hey, yeah, that was really not the greatest thing that happened because my knee still hurts. And what we've learned is, one, we've gotten better at the surgery, like I discussed. So we think some of that 20% or so is because we were so traumatic to the soft tissues around the knee in particular, and that caused such neuropathic pain and musculoskeletal damage that it left a long-term effect from the trauma. So by being less traumatic, we think that number is going to be driven down. The second thing is that multimodal pain management approach. So we think some of that pain that patients are still perceiving after the surgery was because we never really blocked their memory and the body's memory of pain, and they're still left with some neuropathic pain. And that trauma is still kind of deep-seated, and they just perceive that they're still having pain after surgery. And we think the multimodal pain management approach is going to decrease some of that. So we think there's another chunk that we'll get rid of. And then another chunk would be expectations. So what we talk about on a national level, and I lecture to other surgeons, in particular young residents, is that we really have to pick our patients, right? We need to really understand why a patient is having surgery and what we're going to be able to do for them. And that's twofold. So one would be the patient's expectation. So if the patient goes in to the surgery thinking that the expectation of a total knee replacement is a brand new knee, a God-given knee, then their expectation will never be met. And unless I, as a surgeon, talk to them and set their expectations that, hey, you have a bad knee. You have an arthritic knee. It's horrible. It's like driving a car with the tire is worn away and you're now driving on the rim. And I'm going to give you a knee replacement, which is replacing that tire, but it's not the same tire that God gave you. So it's going to be different. And if you're looking for, especially if their other side or contralateral knee feels normal, if you're looking for that, then you really have to stop looking because I'm not going to be able to give you that. I'm going to give you significant pain relief. I'm going to increase your function. You're going to have better range of motion, but how you perceive that is going to be different. And that's what we've learned is that the expectations of patients and what the surgeon gave them as an expectation is not always the same. If I sell you a knee and, hey, I'm going to give you a new knee and you're going to feel great and have no pain, that's not always going to happen. And then you're going to be, the patient, I should say, is going to be sorely disappointed because their expectations weren't met. So we're really trying to set expectations correctly. A lot of that's based on using numbers objectively. We try to get patients to use pain scales. And roughly speaking, if they're above a 7 or 8 on a pain scale of 1 to 10, and that's on a regular basis, then they're going to love joint replacement. So the problem comes is sometimes patients have x-rays which show bone on bone and they're in pain, but on a subjective scale, they're like, well, my pain's a 4. And if you don't ask the patient that, and you do a joint replacement, and now you take their pain down to a 1, sometimes it's a 2 on a pain scale, sometimes it's 0, but on a pain scale postoperatively with patient-reported outcomes, they're usually reporting some type of pain. So that differential of a 4 to a 2 or a 4 to a 1 is not very high. So that patient is going to perceive that surgery as not a good outcome. And that's important, again, for us as surgeons to really dive into to make sure we set the expectations correctly and that we're taking the correct patients to surgery that really need surgery and are really going to benefit from surgery.
Great. That was a great response. Our next question is, what is the life expectancy of a joint replacement?
So our current data, again, you're looking at 25-year data, was roughly a percentage a year. So if I took 100 patients and I did a hip or knee replacement on them, roughly 1% would fail a year. So at 10 years, 90 out of 100 patients would still have that joint replacement in. And at 20 years, it falls off a little bit because it's about 1.1%, give or take. So it goes down to about 78%, right? So, you have close to a 78, 80% chance you'll get 20 years out of the joint replacement, which is great, except if you're the 1 out of 100 who failed the first year. Now, that being said, that was with our original plastics. As you remember in my lecture, the joint is really, the articulation is metal on plastic or ceramic on plastic. And the plastic is the weak link in the system. So that plastic can wear away over time. And what we've done is we've developed new plastics about 8 years ago. So what we think is our new plastics are going to give us much more longevity when it comes to the wearing away process. And so far in the early results, it looks like we're going to cut that number in half.
Okay. The next question is, what is the biggest difference in how you do joint replacement from when you first started?
So the biggest difference would be really, the surgical technique is tremendously different. Again, being less damaging from a traumatic standpoint, and then really how we approach pain management with that multimodal pain management approach. The idea that we're not using PCAs and really running or chasing after people's pain and stopping the pain before it starts has really been tremendously different over my 16-year career.
Okay. And what does the future of joint replacement look like?
I think the future looks like that. We won't be doing anything that we're doing now. I think anytime you look at future of anything, you got to look at disruptive, innovative technology, right? So, if we're going to keep trying to make our current systems better, which is by all means a good idea, but it's really rudimentary when you think about what we're doing. We're taking a native joint that has cartilage and soft tissues, ligaments around it, and we're, kind of cutting that out and putting in metal and plastic and ceramic and plastic. So it's really nowhere near what the body started with. And our goal as surgeons is always to try to get back to, native anatomy. So I think the goal is going to be a biologic cure. I think a lot of labs around the world are looking into this biology. And when you think about stem cells and some scaffolding, and if there's a way that we can recreate and put that cartilage back, that's the future. So, our goal as joint replacement surgeons is really to find a technique to put us out of business, which is interesting enough. And that's everybody's goal, mostly in medicine, right? Cancer doctors are trying to cure cancer, so they're trying to put themselves out of business. So we're all trying to put ourselves out of business. So I think the biologic cure is really what the future holds.
All right, so next question is, how often are you recommending PRP, stem cells, or synovistic type injections prior to joint replacement?
So basically, we'll start with cortisone. So cortisone, we roughly recommend you can do it up to 4 times a year or every 3 months. And the idea there is there's some probable detrimental effect of cortisone causing some soft tissue or cartilage damage in the knee. Now, that being said, our colleagues overseas do injections every month, right? Because they don't have access to joint replacement the way we do. And they see no ill effects with giving 12 shots a year. So the data on cortisone's all over the place, but at least in North America, we're pretty, strict with this. Hey, let's do 4 a year, especially in the younger patient, right? Because they have some cartilage left. Older patient, 85, doesn't want to do joint replacement, has no cartilage. You can inject her or him obviously much more often than you can a younger patient. The hyaluronic acid injections are approved to do every 6 months. You can do them sooner, but you'd have to pay for that out of pocket. PRP, again, paid for out of pocket. You can do them every 6 weeks if you really want to. But roughly, I don't know, 900,000 bucks a pop, whatever it'll end up being, is kind of expensive for something that's only going to last 6 weeks. So I think if you look at, hey, I got to do some modality, high frequency but high cost, it's not very beneficial. And then stem cells, same deal. There's really no data on the PRP and stem cells when it comes to how often we can do those. They're really, I think, regulated more by the cost and how often people are willing to pay for them.
All right, so that is all the questions that I saw in the chat so far. Does anyone on the line have anything else they would like to ask Dr. Selgrath? All right, well, thank you, Dr. Selgrath. That was a great explanation and overview of total joints, where they've been and where they're at now and where they're going to in the future. I just want to remind everybody that on the screen right now, we have the event ID number 44361. You will need that with your full name and credentials to click into the link here on the screen as well, so that you can go in and claim your CE credits. And I think that is it for our session today. So thank you all for attending.
All right, thank you, everybody. Have a great day.
Thanks, Dr. Selgrath. Bye.
Bye-bye.